Good morning, my name is Dr. Pradeep Gangopadhyay. Today I will be talking about the amplitude of accommodation in pre-presbyopic diabetic patients. Diabetes affects the optics and biometry of the eye, and blurring of vision is often the first sign of its presence. Crystalline lens of the human eye is one of the determinants of refraction. It is the only human organ that grows throughout the life of an individual. The lens becomes thicker and increasing age as new fibers are continually added over time. Accommodation is an increase in the dioptric or refractive power of the eye that enables near object to be focused on the retina. The increase in power of the eye occurs because of an increase in the anterior and posterior surfaces of the crystalline lens resulting from contraction of ciliary muscles. Amplitude of accommodation is the maximum amount of accommodation that can be exerted. The crystalline lens in young pre-presbyopic patients with diabetes has been noted to be thicker and more convex when compared with non-diabetics. With increasing age, the crystalline lens becomes thicker and more convex, resulting a presbyopic patient would also require spectacle lens power to see near objects clearly. The diabetic eye acts like a presbyopic eye. With increasing age, the elasticity of the crystalline lens decreases and the amplitude of accommodation is reduced. The purpose of this study was to examine and compare the subjective push-up amplitude of accommodation in pre-presbyopic diabetic patients with age-matched healthy non-diabetic controls in order to better understand the effect of diabetes mellitus on accommodation. It was a cross-sectional hospital-based study performed in a rural tertiary hospital in West Bengal. 54 diabetic patients either with type 1 or type 2 diabetes were selected between the age of 30 and 40 years of age, and 50 age-matched controls were selected for the study. Patients with type 1 and type 2 diabetes mellitus between the age of 30 and 40 years with a best corrected distant vision of equal to or greater than 6/9 were selected for the study. Patients with cataractus lens, diabetic retinopathy, ocular trauma, previous ocular surgery or on medication that affect accommodation like anticholinergic drugs and glaucoma were excluded from the study. A detailed ophthalmological examination including visual acuity, subjective refraction, color vision and anterior and posterior segment assessment was done, followed by subjective amplitude of accommodation was measured with RAF rule using the push-up method. Subjects monoocularly viewed the N5 line while wearing their distant correction, determined the results from subjective refraction. The target N5 was placed in front of the subject's eye at 40 centimeters and the subject was asked to focus on the target with the right eye while the left eye was occluded. Each subject was instructed to focus on the better line as the target was moved closer until the letter line could no longer be held in clear focus, and to report when it first became and remained blurred. The examiner pushed the target at a rate of approximately 5 centimeters per second. The endpoint of the test was the first sustained blur. After this, the other eye was also tested. Now, the mean age and gender between the two groups were compared. There was no significant difference. Hence, we can say that our study is age and gender matched. We can see from our results that the mean amplitude of accommodation in the diabetic group was significantly lower than the control group. We also compared the type of diabetes in the patients. It was also seen that in type 1 diabetes mellitus, the amplitude of accommodation was lesser than in type 2 diabetes. The average duration of diabetes among the study group was 8.12 years. There was a negative correlation between the amplitude of accommodation and the duration of diabetes. We also looked into the diabetic control of the patients and found that mean amplitude of accommodation was seen to be greater in patients with good control than in patients with poor control. Now, there are several previous studies that corroborate with our findings. In different studies, there has been some studies where there is only subjective technique was used, and in some cases objective methods were used. But all come to a conclusion that in diabetic patients there is a lower amplitude of accommodation. Now, the possible hypothesis to explain the loss of accommodation could be that during the periods of hyperglycemia, there is an excess accumulation of glucose in the crystalline lens, which is converted to sorbitol by aldose reductase enzyme and further converted into fructose by the sorbitol dehydrogenase enzyme. When the body of a diabetic person rapidly changes from a hyperglycemic to a hypoglycemic state, excess glucose in the crystalline lens flows into the aqueous humor, but the sorbitol remains in the lens for a longer period. This creates an osmotic gradient resulting in influx of water from the aqueous humor into the lens, producing marked swelling and thickness. The lens is mainly responsible for the loss of amplitude of accommodation in diabetic patients. However, there may be other possible contributors which include loss of ciliary muscle tone, adverse changes to the lens zonules, or deficit in neural input to the ciliary muscle, or changes in geometrical relationship between the lens and the accommodative structures. So from our study, we can conclude that patients with diabetes mellitus showed a lower amplitude of accommodation in comparison to healthy controls, making them susceptible to early onset presbyopia. Longer duration and poor control of diabetes also showed significant influence. Our study was not devoid of any limitations. The sample size was quite small, and we only looked into the subjective push-up method, and we did not look into the objective methods. These are my references. Thank you.
Dr. Pratiru, what were the refractive error status of those patients, those who have selected with the best corrected 6/9, whether they were myopic, whether they are hypermetropic?
So most of the patients that we were looking for were, we looked into, were ametropic patients throughout their life, and they had ametropic.
Because you have mentioned in your materials and methods that you have inclusion criteria was best corrected visual acuity 6/9. So there must be some refractive error. So which refractive error does it?
This makes a difference.
Because it will be biased if you take myopic, because
yes.
they will have a good accommodation. In
And
hypermetropic, they will have pure accommodation.
Poor accommodation. That is
that too in
determining.
diabetic changes.
Yeah.
Hyperhopes develop presbyopia earlier. This is a common finding which all of us come across in our practice. I have noted that. Whether they are diabetic or not diabetic.
Yeah, definitely.
That doesn't matter.
Yeah.
Very important inclusion criteria you should have mentioned.
Yes, what type of refractive error?
Refractive error
Yes.
those patients are having.
That would make your study complete. Because it makes a lot of difference.
Because selected, if you take selectively these myopic patients, then the study has got no meaning, because they only hypermetropic, then again the study will have no meaning. So you have to have the proper selection of.
Clarify also how many patients were myopic, how many were hyperopic, how many had mixed astigmatism or compound myopic, as something like that. It should be refractive error based also, because this is an important factor in judging whether actually diabetes is responsible for the presbyopic error
Or the refractive error per se. That is a. Sample size was very less, and the collection was not very proper.